Move on now to spinal cord injury. Spinal cord injury is caused by trauma or damage to the spinal cord. It can result in either a temporary or permanent alteration in the function of the spinal cord. About 12,000 Americans suffer spinal cord injuries every year. The number of persons living with spinal cord injuries is about 260,000. Young adult men between the ages of 16 and 30 have the greatest risk for spinal cord injury. 81% of people with spinal cord injury are male. There's also been an increase in the number of older adults with spinal cord injury. This trend toward older age at the time of injury explains the overall increase in mean age of people with spinal cord injury from 28 years in the 70s to 40 years at the current time. With improved treatment strategies, even the very young patient with a spinal cord injury can anticipate a long life. The potential for disruption of individual growth and development, altered family dynamics, economic loss in terms of employment issues, and the high cost of rehab and long-term health care make spinal cord injury a major problem. Although many people with spinal cord injury can care for themselves independently, those with the highest level of injury may require round-the-clock care at home or in a long-term care facility. Almost 90% of patients with spinal cord injury are discharged from the hospital to home or another non-institutional residence. The remaining 10% are discharged to nursing homes, chronic care facilities, or group homes. Spinal cord injuries are usually from trauma. The most common causes are motor vehicle accidents, falls, violence, sports injuries, and other miscellaneous causes. J.N. is a 32-year-old woman being brought to the emergency department after being thrown from her car following a motor vehicle accident. She was not wearing a seatbelt, she's awake and crying, and states she can't move or feel her legs. J.N. anxiously asks you if she broke her back and cut her spinal cord. She also asks if she'll be paralyzed for life or if it can be reversed. Based on your knowledge of the pathophysiology underlying spinal cord injury, how will you answer her? Let's talk about etiology and pathophysiology. The spinal cord is wrapped in tough layers of dura and is rarely torn or transected by direct trauma. Spinal cord injury can be due to cord compression by bone displacement, interruption of the blood supply to the cord, or traction resulting from pulling on the cord. Penetrating trauma such as gunshot and stab wounds can result in tearing and transection. The initial mechanical disruption of axons as the result of stretch or laceration is referred to as the primary injury. Secondary injury refers to the ongoing progressive changes or damage that occurs after the initial injury. There are several theories about what causes this ongoing damage, including free radical formation, uncontrolled calcium influx, ischemia, and lipid peroxidation. Apoptosis or cell death occurs and sometimes may continue for weeks or months after the initial injury. Thus, the complete cord damage, previously thought to be transection in severe trauma, is related to autodestruction of the cord. Hemorrhagic areas in the center of the spinal cord appear within an hour, and by 4 hours there may be infarction in the gray matter. This ongoing destructive process makes it critical that the initial care and management of the patient with a spinal cord injury be initiated as soon as possible to limit further destruction of the spinal cord. This picture illustrates the cascade of events causing secondary injury after traumatic spinal cord injury. The resulting hypoxia reduces the oxygen levels below the metabolic needs of the spinal cord. lactate metabolites, and an increase in vasoactive substances, including norepinephrine, serotonin, and dopamine, are noted. At high levels, these vasoactive substances cause vasospasm and hypoxia, leading to subsequent necrosis. Unfortunately, the spinal cord has minimal ability to adapt to vasospasm. By 24 hours or less, permanent damage may occur because of the development of edema. The edema secondary to the inflammatory response is particularly harmful because of the lack of space for tissue expansion. Therefore, compression of the spinal cord occurs. Edema extends above and below the injury, thus increasing the ischemic damage. The extent of the neurologic damage caused by the spinal cord injury results from the primary injury damage and secondary injury damage. Because secondary injury progresses over time, the extent of the injury and prognosis for recovery are most accurately determined at least 72 or more hours after the injury. CN cervical spine X-rays and CT reveal fractured C7-8 vertebrae. Physical exam demonstrates total loss of reflexes, sensation, and movement below the level of the injury. You recognize these symptoms as spinal shock. What is spinal shock and how does it differ from neurogenic shock? Spinal shock is characterized by decreased reflexes, loss of sensation, and flaccid paralysis below the level of the injury that lasts days to months. About half of the people with acute spinal cord injury experience this temporary neurologic syndrome known as spinal shock. This type of shock is characterized by, again, decreased reflexes, loss of sensation, and flaccid paralysis below the level of the injury. Neurogenic shock, in contrast to spinal shock, is due to the loss of vasomotor tone caused by the injury and is characterized by hypotension and bradycardia. Loss of sympathetic nervous system innervation causes peripheral vasodilation, venous pooling, and decreased cardiac output. These effects are generally associated with a cervical or high thoracic injury at T6 or higher. Spinal cord injuries are classified by the mechanism of injury and the level of injury and the degree of injury. The major mechanisms of injury are flexion, hyperextension, flexion rotation, extension rotation, and compression. The flexion rotation injury is the most unstable of all injuries because the ligamentous structures that stabilize the spine are torn. This injury is most often implicated in severe neurologic deficits. The skeletal level of the injury is the vertebral level where there is most damage to vertebral bones and ligaments. Neurologic level is the lowest segment of the spinal cord with normal sensory and motor function on both sides of the body. The level of injury may be cervical, thoracic, lumbar, or sacral. Cervical and lumbar injuries are most common because these levels are associated with the greatest flexibility and movement. If the cervical cord is involved, paralysis of all four extremities occurs, resulting in tetraplegia, which was formerly called quadriplegia. However, when the damage is low in the cervical cord, the arms are rarely completely paralyzed. If the thoracic, lumbar, or sacral spinal cord is damaged, the result is paraplegia, which is paralysis and loss of sensation in the legs. Figure 61.6 shows the affected structures and functions at different levels of cord injury. Here is a depiction of the mechanisms of injury. Many situations can produce these injuries. These are just examples. So A is a flexion injury of the cervical spine rupturing the posterior ligaments. B is a hyperextension injury of the cervical spine that ruptures the anterior ligaments. Compression fractures crush the vertebrae and bony fragments into the spinal canal. And flexion rotation injuries of the cervical spine often result in tearing of ligamentous structures that normally stabilize the spine. The degree of spinal cord involvement may be either complete or incomplete. Complete cord involvement results in total loss of sensation and motor function below the level of the injury. Incomplete cord involvement results in a mixed loss of voluntary motor activity and sensation and leaves some tracts intact. The degree of sensory and motor loss varies depending on the level of the injury and reflects the specific nerve tracts damaged. There are 6 syndromes associated with incomplete injuries: central cord syndrome, anterior cord syndrome, Brown-Séquard syndrome, posterior cord syndrome, cauda equina syndrome, and conus medullaris syndrome. The central cord syndrome is caused from damage to the central spinal cord, occurs most commonly in the cervical cord region. It's common more often in older adults. Motor weakness and sensory loss are present in both upper and lower extremities. Upper extremities are affected more than lower ones. Anterior cord syndrome is caused by damage to the anterior spinal artery. It results in compromised blood flow to the anterior spinal cord. Typically, this results from injury causing acute compression of the anterior portion of the spinal cord, often a flexion injury. Motor paralysis and loss of pain and temperature sensation below the level of the injury are noted. Because posterior cord tracts are not injured, sensation of touch, position, vibration, and motion remain intact. Brown-Séquard syndrome results from damage to one half of the spinal cord. This is depicted in figure 61-7. Typically, it results from penetrating injury to the spinal cord. The ipsilateral, or same side as the injury, has a loss of motor function and position and vibratory sense and vasomotor paralysis. The contralateral side, or the opposite side, has a loss of pain and temperature, sensation below the level of the injury. Posterior cord syndrome results from compression or damage to the posterior spinal artery. It's a very rare condition. Generally, the dorsal columns are damaged, resulting in a loss of proprioception. Pain, temperature sensation, and motor function below the level of the injury remain intact. Conus medullaris syndrome and cauda equina syndrome result from damage to the very lowest portion of the spinal cord, the conus, and the lumbar and sacral nerve roots, the cauda equina. Injury to these areas produces flaccid paralysis of lower limbs and areflexic or flaccid bladder and bowel. The manifestations of spinal cord injury are generally the direct result of trauma that causes cord compression, ischemia, edema, and possibly cord transection. Manifestations of SCI are related to the level and degree of injury. The patient with an incomplete injury may demonstrate a mixture of manifestations. The higher the injury, the more serious the sequelae because of the proximity of the cervical cord to the medulla and brainstem. This is a picture that shows the result of injuries at various levels. A C4 injury results in tetraplegia, which is complete paralysis below the neck. C6 results in partial paralysis of hands and arms as well as the lower body. T6 involves paraplegia and results in paralysis below the chest, and L1 results in paraplegia and paralysis below the waist. The American Spinal Injury Association, or ASIA, has an impairment scale that's commonly used for classifying the severity of impairment resulting from spinal cord injury. It combines assessment of motor and sensory function to determine neurologic level and completeness of injury. The ASIA impairment scale is useful for recording changes in neurologic status and identifying appropriate goals for rehab. Movement and rehab potential are related to specific locations of the spinal cord injury. In general, sensory function closely parallels motor function at all levels. In the textbook, see Table 61.4 for more information. Respiratory complications closely correspond with the level of injury. Cervical injuries above the level of C4 represent special problems because of the total loss of respiratory muscle function. Mechanical ventilation is required to keep this patient alive. At one time, the majority of these patients died at the scene of the injury, but with improved emergency medical services, more of these patients are surviving the initial events of the spinal cord injury. Injury or fracture below the level of C4 results in diaphragmatic breathing if the phrenic nerve is functioning. Even if the injury is below C4, spinal cord edema and hemorrhage can affect the function of the phrenic nerve and cause respiratory insufficiency. Hypoventilation almost always occurs with diaphragmatic respirations because of the decrease in vital capacity and tidal volume, which occurs as a result of impairment of the intercostal muscles. Cervical and thoracic injuries cause paralysis of abdominal muscles and often the intercostal muscles. Therefore, the patient cannot cough effectively enough to remove secretions, leading to atelectasis and pneumonia. An artificial airway provides direct access for pathogens, making bronchial hygiene and chest PT extremely important measures to reduce infection. Neurogenic pulmonary edema may occur secondary to a dramatic increase in sympathetic nervous system activity at the time of injury, which shunts blood to the lungs. In addition, pulmonary edema may occur in response to fluid overload. Any cord injury above the level of T6 greatly decreases the effect of the sympathetic nervous system. Bradycardia occurs. Peripheral vasodilation results in hypotension. A relative hypovolemia exists because of the increase in the capacity of the dilated veins. Cardiac monitoring is necessary. In marked bradycardia, a heart rate of less than 40 beats a minute, appropriate drugs, such as atropine, are used to increase the heart rate and prevent hypoxemia. The peripheral vasodilation reduces the venous return to the heart and subsequently decreases cardiac output, resulting in hypotension. IV fluids or vasopressor drugs may be required to support the blood pressure. Urinary retention is a common development in acute spinal cord injury and spinal shock. While a patient is in spinal shock, the bladder is atonic and becomes overdistended. An indwelling catheter is inserted to drain the bladder. In the post-acute phase, the bladder may become hyperirritable, with a loss of inhibition from the brain resulting in reflex emptying. Chronic indwelling catheterization increases the risk of infection. If the spinal cord injury has occurred above the level of T5, the primary GI problems are related to hypomotility. Decreased GI motor activity contributes to the development of paralytic ileus and gastric distension. A nasogastric tube for intermittent suctioning may relieve the gastric distension. Metoclopramide or Reglan may be used to treat delayed gastric emptying. The development of stress ulcers is common because of excessive release of hydrochloric acid in the stomach. Intra-abdominal bleeding may occur and is difficult to diagnose because the person with a spinal cord injury may experience no pain or tenderness. Continued hypotension in spite of vigorous treatment and decreased hemoglobin and hematocrit may be indications of bleeding. Expanding girth of the abdomen may also be noted. Loss of voluntary neurogenic control over the bowel results in a neurogenic bladder. A neurogenic bowel. In the early period after injury, when spinal shock is present, and for patients with an injury level of T12 or below, the bowel is areflexic and the sphincter tone is decreased. As reflexes return, the bowel becomes reflexic and sphincter tone is enhanced, and reflex emptying occurs. Both areflexic and reflexic neurogenic bowel can be managed successfully with a regular bowel program coordinated with a gastrocolic reflex to minimize fecal incontinence. A major consequence of lack of movement is the potential for skin breakdown over bony prominences in areas of decreased or absent sensation. Pressure ulcers can occur quickly and can lead to major infection and sepsis. You might remember Christopher Reeves, who was a quadriplegic after injury in a fall from a horse, and his cause of death was sepsis from an infected decubitus. Poikilothermism is the adjustment of the body temperature to the room temperature. This occurs in spinal cord injury because of the interruption of the sympathetic nervous system, which prevents peripheral temperature sensations from reaching the hypothalamus. With spinal cord disruption, there is also decreased ability to sweat and shiver below the level of the injury, which also affects the ability to regulate body temperature. The degree of poikilothermism depends on the level of the injury. Patients with high cervical injuries have a greater loss of the ability to regulate temperature than those with thoracic or lumbar injuries. Nasogastric suctioning may lead to metabolic alkalosis, and decreased tissue perfusion may lead to acidosis. Electrolyte levels, including sodium and potassium, can be altered by gastric suctioning. Monitor these electrolytes until suctioning is discontinued and a normal diet is resumed. Loss of weight greater than 10% is common. The person with the spinal cord injury has greater nutritional needs than other types of patients who are immobilized. A high-protein diet helps to prevent skin breakdown and infections and decrease the rate of muscle atrophy. Deep vein thrombosis is a common problem accompanying spinal cord injury during the first 3 months. It's more difficult to detect a DVT in a person with a spinal cord injury because the usual signs and symptoms, such as pain and tenderness, will not be present. Pulmonary embolism is one of the leading causes of death in patients with spinal cord injury. CT scan is now the gold standard in diagnosing stability of the injury, location and degree of injury, and degree of spinal canal compromise. Cervical x-rays are obtained when CT scan is not readily available. However, often there is difficulty on a cervical x-ray to visualize C7 and T1, making it difficult to fully evaluate cervical spine injury. MRI is used to assess for soft tissue and neurologic changes, and when there is unexplained neurologic deficit or worsening of neurologic status. A comprehensive neurologic examination is performed along with assessment of the head, chest, and abdomen for additional injuries or trauma. Patients with cervical injuries who demonstrate altered mental status may also need a CT angiogram to rule out vertebral artery damage. In collaborative care, your immediate goals are to make sure that there is a patent airway, adequate ventilation, and adequate circulating blood volume, and to prevent extension of the cord damage by secondary injury. The emergency management and initial care include ensuring a patent airway, stabilizing C-spine, administering oxygen via nasal cannula or non-rebreather mask, establishing IV access with 2 large bore catheters to infuse saline or lactated ringers as appropriate, assess for other injuries, and control external bleeding. You might need to obtain cervical spine x-rays, CT or MRI, and prepare for stabilization with cranial tongs and traction. The ongoing monitor will include monitoring vital signs and level of consciousness, oxygen saturation, cardiac rhythm, and urine output. You want to keep the patient warm, monitor for urinary retention and hypertension, and anticipate the need for intubation if the gag reflex is absent. For injuries at the cervical level, all body systems must be maintained until the full extent of the damage can be evaluated. The support required by the patient is less intense for spinal cord injuries of the thoracic and lumbar vertebrae. Respiratory compromise is not as severe, and bradycardia is usually not a problem. Specific problems are treated symptomatically. After stabilization at the injury scene, the person is transferred to a medical facility. A thorough assessment is done to specifically evaluate the degree of deficit and to establish the level and degree of injury. A history is obtained with emphasis on how the incident occurred and the extent of the injury is perceived by the patient immediately after the event. Assessment involves testing muscle groups rather than individual muscles. Test muscle groups with and against gravity, alone and against resistance, and on both sides of the body. Note spontaneous movement. Ask the patient to move legs and then hands. Spread fingers, extend wrists, and shrug shoulders. After assessment of motor status, a sensory examination, including touch and pain as tested by pinprick, should be carried out, starting at the toes and working upward toward the head. If time and condition permits, also assess position sense and vibration. The types of injury mechanisms that cause spinal cord trauma, especially those involving the cervical cord, may also result in brain injury. Therefore, assess for a history of unconsciousness, signs of concussion, and increased intracranial pressure. In addition, perform a careful assessment for musculoskeletal injuries and trauma to internal organs. Because the patient has no muscle, bone, or visceral sensations, the only clue to internal trauma with hemorrhage may be a rapidly elevated BP and increasing pulse. Examine the urine for hematuria, which is also indicative of internal injuries. Move the patient in alignment as a unit, called log rolling, during transfers and when repositioning to prevent further injury. Monitor respiratory, cardiac, urinary, and GI functions. The patient may go directly to surgery following initial immobilization and stabilization, or to the ICU for monitoring and management. Non-operative treatments are focused on stabilization of the injured spinal segment and decompression either through traction or realignment. Stabilization methods eliminate damaging motion at the injury site. These methods are intended to prevent secondary spinal cord damage caused by repeated contusion or compression. Surgery stabilizes the spinal column. Early cord decompression to decrease pressure may result in reduced secondary injury to the spinal cord and therefore improve outcomes. Other criteria used in the decision for early surgery include evidence of cord compression, progressive neurologic deficit, compound fracture of the vertebra, bony fragments may dislodge and penetrate the cord, and penetrating wounds of the spinal cord or surrounding structures. The more common surgical procedure include decompression laminectomy by anterior cervical and thoracic approaches, with fusion posterior laminectomy with the use of acrylic wire mesh and fusion, and insertion of stabilizing rods. JN's cervical spine is immobilized, and a neurosurgeon is consulted. Vasopressor drugs, such as dopamine, also called intropin, are used in the acute phase as adjuvants to treatment. These agents are used to maintain the mean arterial pressure at a level greater than 90, so the perfusion to the spinal cord is improved. Drug metabolism is altered in patients with a spinal cord injury. Therefore, drug interactions may occur. The difference in drug metabolism correlates with the level and completeness of the injury, with greater change apparent in people with cervical injury than in those with injury at lower spinal levels.